السلام عليكم ورحمة الله وبركاته. يسر يمانا Yemeni American Medical Association ويمانا Education أن تستمر معكم بتقديم الإدوكيشنال سيريز. اليوم راح نستمر معكم بالكارديوفاسكولار سيريز، ومحاضرة اليوم بعنوان Acute Coronary Syndrome Part 2 يقدمها الدكتور مصطفى هاشم.
إن شاء الله. Okay, so let's make sure my computer works here. Okay, good. Great. Beautiful. Assalamu alaikum. Inshallah, this will be lecture number 2 on acute coronary syndrome. And last time we talked about from patient presentation till the patients get to the pre-perfuse and the cath lab and so on. We talked about multiple salient points and so on. Hopefully, inshallah, the lecture will be uploaded and then will be open for any question, inshallah, in the future. Still have at least 2 more lectures other than this one in acute coronary syndrome. But today we're going to mostly talk about, mostly related to pharmacology related, how we treat patients when we get them from the ER to the hospital, to the cath lab and so on, and maybe even and then after discharge, how we handle those patients, mostly pharmacology details. So as usual, we start normally with a question just to stimulate the thoughts and then make people think about this. So the first case would be if you have this 64 years old gentleman. Now every wording here was placed like makes sense in it, and you have to pay attention to it. 64 years old, came to emergency room, has 5 days history of chest pain, resistant, stable angina on aspirin therapy, metoprolol, has history of hypertension and TIAs. And patient has severe COPD on oxygen intermittently, pulse in the 50s, blood pressure 110, exam is normal. EKG showed some ST depressions, and the inferior leads, troponin was elevated. Pain has improved after heparin, IV, and nitroglycerin. EKG got better. Angiogram was planned for the next day. Now, in addition to statin therapy, which we know that high-dose statin is beneficial for all these patients, there's no discussion about it. What should medical therapy we give to these patients? Should we give metoprolol intravenously, which is a lot of people have been used in the past? Should we give 300 milligram clopidogrel, 60 milligram prasugrel, and we're going to discuss all these issues, or we give intravenous aptifidide or intravenous cangrelor infusion. Second case, so just bear in mind in this patient, think about it. Hopefully I'm not too fast. I'm too fast, ask me to slow, I will slow down. Second case is a 75-year-old gentleman, history of STEMI, undergoes PCI to occluded LAD. It was uncomplicated course, EFs 38%. Started on dual antiplatelet therapy, aspirin, ticagrelor, metoprolol, lisinopril, spironolactone, and atorvastatin. Based on the results of COLCAT trial, you also consider adding colchicine at 0.5 milligram daily, and we're going to discuss COLCAT trial. The options are, would we expect to effective colchicine on these patients for the next few years? Significant decrease in mortality, decreased risk of stent thrombosis, significant decreased risk of recurrent MI, 10% chance of diarrhea, or all the above. I'm not sure how the practice and other areas, but some people discuss colchicine in patients with acute coronary syndrome. Third case, much simpler, 70 years old, has non-STEMI, history of AFib, hypertension, diabetes. Medication include ACE, aspirin. EKG shows AFib with the ventricular rate of 80. Angiogram shows critical concerns in the LAD. PCI was performed. Which stent to use? Do you use bare metal stents or drug-eluting stents? We're going to discuss that also briefly during this presentation. Last patient, same patient, basically PCI successfully was performed. Drug-eluting stents was placed in this patient. as an answer for the last question. And then recommend antiplatelet anticoagulation for these patients. Should we send the patient abciximab with double antiplatelet therapy, discontinue aspirin after 1 week, or we give Coumadin and double antiplatelet therapy, discontinue aspirin after 1 week, or apixaban and DAP for 12 months, warfarin and DAP for 12 months, and DAP also for 3 months, and then switch to warfarin and aspirin. So these are issues it comes through our discussion, through our teaching for our residents, students, and so on. I have no conflicts. So what kind of adjuvant antiplatelet therapy, anticoagulant therapy we use for patients for patient with ACS? Of course, as we know, the landscape has changed over the last 15 years, starting from the Triton trial, which was in 2007 with the prasugrel. And then we have the Plato trial. Ticagrelor has also published in 2009 that changed our practice. And then we're using less and less of 2B3A, especially upstreaming 2BA from the ER, as we discussed in the previous lectures. There's the battle settled in terms of the using of high dose statin in patients as secondary prevention for coronary artery disease. There are better PCI devices nowadays, especially the second generation drug-eluting stents, with decrease the amount of or the duration of the antiplatelet therapy for these patients. Also, as we discussed last lecture, the transradial approach for this patient, class 1 indication now, patients with either elective or primary interventions, and earlier reperfusion, revascularization in these patients. So things has evolving over the last 15 years, and we learned a lot from all the studies that's been done, and it's a moving target. Rahim, this is not moving. All right, good. So early antiplatelet therapy, we know double antiplatelet therapy is a class 1 recommendation. Normally start with aspirin, then you can choose either clopidogrel or ticagrelor. We don't use prasugrel as uploading because there's a high risk of bleeding, and we're going to go over the study which discuss that. Normally, this is the OCAS trial for the pre-treatment. So basically, this was published in the New England Journal 2013. A patient with ACS randomized to either a prasugrel 30 milligram given at the time of ACS versus 60 milligram after coronary angiography. There was no benefit in primary endpoint, either cardiovascular death or MI or urgent revascularizations for rescue 2B3A or rescue 2B3A patients. TIMI major bleeding higher in pre-treatment group, twice higher overall and 3 times higher in PCI patients, 6 times higher risk of life-threatening bleeding in this patient. So we don't upload with prasugrel nowadays from the ER. It's a decision we make in the cath lab. Almost get treated like 2B3A when we decide only in the cath lab whether to use prasugrel or not. And then obviously there are some preservation using prasugrel, especially patients with elderly patients more than 75. Normally, if we want to use it, let's say the patient's allergic to other medications, we use 5 milligram, or of course we don't use it if the patient has history of TIA or stroke, or patients have a low weight. So in ACS, the incidence of death, MI, CVA was lower in those treated with prasugrel compared to ticagrelor with no excessive bleeding. This is there was a notion after the ticagrelor came in, we use a lot of ticagrelor, but the ISAR trial, which was published in 2019, compared prasugrel and ticagrelor, and there actually is no difference in using them in either comparing prasugrel to ticagrelor. And then we started using more prasugrel because prasugrel became a generic medication. Ticagrelor is still non-generic, it's very expensive. So you'll see the trend throughout the US. We're using less ticagrelor since this trial was published. Upstreaming to be upstream 2B3A, as we discussed last lecture. Also this time, we don't use it as As from the ER, we use it provisionally only in the cath lab, especially the patient is not loaded. Personally, I use it if the patient is not loaded. I load the patient during the cath lab with B2Y2 inhibitors, and then I give them one dose of 2B3A. So just buying the time for the B2Y2 to work. So for the from 2014 guidelines, and there is actually recent guidelines published, I think last week or the week before in the United States. Last time when we gave the lecture, that guidelines was not published. Inshallah, we'll discuss it in the future when we get all the materials out. But in general, so class 1 indication is upstream use for patients who come with acute coronary syndrome. We use either clopidogrel or ticagrelor and continue for 12 months. 2A, we use ticagrelor preferred over clopidogrel. And the 2B, we use 2B3A inhibitors as pre-treatment, and if pre-treatment with B2Y2 inhibitors. Now, if patient was not treated with B2Y2 inhibitors, then maybe you can use 2B3A as professional. It depends on the cardiologist what he prefers. But the practice, actually, personally, I've been using more clopidogrel than ticagrelor over the last 2 years. Part of it because of the cost, part of it, I have not seen any difference in terms of results on this patients personally. In terms of P2Y2 inhibitors, class 1, we load with any drug. Normally, we load either with clopidogrel or ticagrelor. We rarely load with prasugrel. Normally, we prefer patients only in the cath lab get loaded if we want to use prasugrel, but we never use, as we discussed, and this can be a board question for you guys, never used in patient with CVA, TIA, and avoid if a patient's older than 60 now. If older, no, less than 60 kilogram weight, but if they're older than 75, sometimes you can use, but you can use a low dose. Sometimes we do use it because patients, they cannot tolerate ticagrelor because of bradycardia, or they are allergic to clopidogrel and so on. So, and then we continue for 12 months as a class 2A, and then we're going to discuss this a little bit more in details. Now, 2B3A inhibitors, if high risk features, troponin positive, sometimes we use it. If the patient was not loaded with the P2Y2 inhibitors, and it's a class 2A is reasonable anyway. So we leave some stuff for the cardiologist to decide in terms of, let's say you get a patient in the cath lab, high thrombus load, you want to use 2B3A, and then you already loaded, let's say, a half hour earlier with clopidogrel, ticagrelor. It takes time for especially the clopidogrel to kick in, especially you give only 300 milligram, not 600. So the primary PCI and STEMI, what to give, which P2Y2 inhibitors, class 1, there's some to give to P2I anyone you want. There's some caveat with prasugrel, as we discussed. In terms of bavloridine or heparin, both are class 1. Bavloridine has less bleed, and then we avoid fendovernax. Now, mostly nowadays in the United States, we don't use bavloridine anymore. And if you look at even the studies done comparing bavloridine and heparin, the heparin trials, they were including 2B3A inhibitors on those patients, and there is a high risk of bleeding. That's why bavloridine was less bleed, but actually it fell out of favor because of cost. There is some guides, thrombosis in these patients. And so we don't use it as much nowadays, bavloridine. So feel free to use just the old cheap heparin, and then load your patients with another cheap P2Y2 inhibitors. Or the 2B3A inhibitors used as a class 2A, if a patient was not loaded, all are equivalent, either of the 2B3A, whether you use eptifibatide or other ones, and no extreme use in these patients. Normally we reserve to use it only in the cath lab for the 2B3A as we speak at this point. Now, there is another expensive, this intravenous cangalor, which is a P2Y2 receptor inhibitor. Now, its half-life is short, less than 5 to 6 minutes. And of course, people, the companies are advertising it as such. So they tell you why don't you use it, and the patient with STEMI or non-STEMI, you want to take them to the cath lab and say in case they have 3 vessel disease or a left main, you want to send them for a bypass surgery. So you can stop the P2Y2 inhibitors with no problem. Within a half hour, that medicine is not in the system. They say half-life is 5 to 6 minutes, but the cost is very prohibitive. And then if you think about it, how many patients whom we cath, whether they have STEMI or non-STEMI, we send for bypass surgery, actually nowadays is very small number. Now, when you treat the big number, you don't treat the small number. It's, let's say, less than 10% of your patients you send for bypass, you're not going to use a very expensive drug just to treat that. Though you get a lot of push about it nowadays, but it really never take off. Now, if you look at the study, even the study, the Champion PCI trial published in 2009, they compare IV Cangalore 30 minutes before BCI or 600 Plavix. There was actually Cangalore was not superior to oral clopidogrel in reducing the composite endpoint of death, MI, myocardial infarction, and so on. So the only benefit from it is those patients whom they may need open heart surgery, which you cannot really predict before. And if you think about it, even patients with non-STEMI who may need an open heart surgery, may have a 3 vessel disease. Most of those patients are old and they have other comorbid conditions. So really we then make our decisions based on that, because the majority of our patients, actually, they don't go for bypass surgery. Most of them, they get treated by in the cath lab. And even if they have left main disease, nowadays we do have solution for left main disease in the cath lab with all the hemodynamic support we do for these patients in the cath labs. Now, optimal adjuvant medical therapy during ACS events. Basically, you have this menu. We use DAP, dual antiplatelet therapy. We use beta blockers. We don't use nowadays IV beta blockers, mostly oral beta blockers. In terms of the ACE and ARBs, we use them for patients who have LV dysfunction, anterior MI, diuretics. We use aldosterone inhibitors if your EF is less than 40%. High dose statins, as we discussed, there's no question about it. Now, don't feel obligated to use ACE inhibitors or ARBs if your EF above 40%, if you don't have anterior MI. Of course, diabetic patients, and if you want to use this for hypertension, feel free. But these are the what we use. So drugs to avoid an ACS IV beta blockers because the risk of hypertension and shock. Of course, at one point through our training over the years, they were using IV beta blockers like the 5 milligram every 15 minutes. Yes, that proves to decrease the amount of arrhythmias, but definitely with a higher increase of shock and hypertension. So now we don't use beta blockers. We use oral beta blockers if needed. IVS inhibitors, again, we don't use. IV2B3A, we don't use. Reserve only for the cath lab. Prasugrel prior to coronary angiogram, we try not to use. We make a decision in the cath lab. O2 administrations, if O2 saturation more than 90s, there's no benefit. So basically, I mean, oxygen, we consider it as a drug here. So if you're sat more than 90%, you don't have to use. There was some Scandinavian study about oxygen therapy that if you don't oxygen, increase the size of the MI, that showed there's no difference actually. But if your oxygen is less than 90%, feel free to use oxygen. Long-term antithrombotic therapy and other secondary prevention in patients with ACS. So basically, we use DAP for 12 months, if not high bleeding risk. If high bleeding risk, you can decrease the duration up to 6 months. Clearly, the classic teaching patients with ACS, we're going to use for 1 year 2B3A, except if they have risk of bleeding. After PCI, cabbage, or medical management, of course, you use a DAP2. Unnecessary to prolong DAP beyond 12 months. Now, individualized decision have to be respected here. Some patients, we do very complex coronary interventions, like, there are multiple, high, complex stenting, like, we don't want to go into details at this point, but if there's a complex intervention and you feel your patient's a very high risk for stent thrombosis, then maybe you prolong it, but there's no much benefit after 12 months for the most part. And there is no strong recommendation for platelet function or pharmacogenomic testing. As you remember, 6, 7, 8 years ago, we used to test for genetics, especially for use for Plavix. They say Caucasian. Some of them are resistant to clopidogrel. Nowadays, there's no recommendations for that. So DAPT with everolimus drug-eluting stents. Now, the MACE is basically major advanced cardiac events or stent thrombosis. It's very low, 0.2 and 0.4%. That's if you use more than 12 months, but at the expense of higher risk of bleeding. And this is where the recommendation came in. You don't use dual antiplatelet therapy for more than 12 months because the stent of thrombosis nowadays with second generation stents is really, really low. But there is a high risk of bleeding, especially in elderly people. Now, some of my patients, actually, they come and tell me, hey, I want to continue taking it. I'll just let them take it. So it's a hesitant on recommendation for long beat DAPT. So nothing more than a class 2B at this point. So basically, don't use more than 12 months for these patients. Now, this is different, of course, if you think about it for elective interventions, only 6 months. We use 6 months actually for dual antiplatelet therapy. Now, there is a monotherapy, and this came up, actually, discussion came up over the last couple of years, whether you can use monotherapy in these patients. Actually, it is feasible, and as you remember the Twilight trial, which was published in 2019 in New England Journal for high-risk PCI patients, sacral monotherapy after 3 months and less bleeding than DAPT with no higher risk of death, myocardial infarction, or stroke. So it's your clinical decision. There is enough data there to support use monotherapy, and this one done with ticagrelor. So we used the drug which showed up and which was studies in this patient. So you have enough data to support you. Nobody can question you if you have a high risk patients of bleeding for using monotherapy in these patients. So of course, cardiac rehab, risk factor modification is very important. Patients who go to cardiac rehab, they get less MI in the future, less mortality. And mostly the way I educate my patients about this is because of the education they get in cardiac rehab about risk factor modifications rather than the actual exercise they get in cardiac rehab. Now, this is the colchicine trial we mentioned earlier through that question. Basically, colchicine, as we know, we use it for pericarditis, we use it for gout, and now because it has anti-inflammatory drug, it used to be cheap. Now it's a little bit more expensive because it's anti-inflammatory. The Polkat trial tested the use of colchicine after recent MI, 0.5 milligram one daily. And the assumption was it's reducing cardiovascular events compared to placebo. It's a well-documented rule in inflammation, as we know. Now, there are other people who use some chemotherapy in the CANTOS trial, but that's very costly. And there was higher increase of fatal infections, so nobody is using it. But the colchicine was much cheaper, and that's why it was tested and tried to we use it. Now, if you look at the curve, there is the hazard ratio is much better or less with the using colchicine more than placebo. But if you dissect it, if you dissect it more, you will see the cardiovascular death is 0.8 and 1. No major difference actually comparing with placebo. Resuscitation for cardiac arrest, no major difference. Myocardial infarction, barely difference. Mostly you get a benefit in a stroke or urgent hospitalization of angina leading to revascularization, which you can see the reduction is, I mean, at least 50% or more than 50% in terms of the stroke. But in terms of benefit of cardiovascular death, resuscitations, cardiac arrest, myocardial infarction, really there's no major benefit in this trial if you dissect the trial carefully. But of course, you get a push of using colchicine. It doesn't mean I don't use it myself. I do sometimes with patients with end-stage stenosis. I mean, I use it with my PAD patients. Have one of my partners who use it. The patient will come with a chest pain, you give them colchicine and so on. But if you look at the COLCAT trial, really there's no major benefit in terms of cardiovascular death or recurrent myocardial infarction. Now, so relatively low risk group and excellent guided medical therapy. Almost one of the five stopped the drug, mostly because of side effects. As you know, colchicine can cause GI upset and can cause diarrhea in this patient. There's some increase in pneumonia and GI, low events rate with no reduction in MI or death, as we discussed. So now we have one of our patients who presented has AFib, and that's why we're coming here. DOACs and using Rivaroxaban, which I think, I don't know what you call it, guys, in Yemen, we call it here Xarelto. But this ATLAS trial, which I think it was published in 2012, a large study just using anti-factor A in patients with acute coronary syndrome, and they studied like 2.5 or 5 milligram on the background of DAPT in these patients. There is a primary endpoint, cardiovascular death, MI, CVA was decreased, number to treat is 55, cardiovascular decreased, but there is an increased bleeding, especially intracranial bleed, though it's a low number. That's why we shy from using it. Actually, the drug company, they want us to use Xarelto or Rivaroxaban in every patient who have coronary disease, but really we're very hesitant to use it because when it's used in this large study, there's a high risk of major bleeding and intracranial hemorrhage. So,
محاضرة طبية من أمريكا.
right. So great, thanks. So the other dilemma we get these patients who gets like they get STEMI or non-STEMI, but at the same time they get a PE or they have a DVT or they have AFib, right? So you end up what to use in this patient. So the Augustus trial, which was published in 2019, they have more than 4,000 patients. These patients, they have AFib. They receive drug-eluting stents and so on. They basically comparison trial use either a warfarin, P2Y12 inhibitors, and then you use abciximab and 2-5 inhibitors. Then of course you use either aspirin or placebo in these patients. The major bleeding, abciximab is superior to vitamin K inhibitors. So basically, and that's why we don't use nowadays warfarin with this patient. We use abciximab. It doesn't mean that if the patient cannot afford abciximab, we don't use a warfarin. We still do, but definitely abciximab is superior to vitamin K inhibitors. Death and hospitalization, abciximab is superior. Ischemic events, there was no difference in these patients. Of course, when you say abciximab, then of course you can use Xarelto on these patients. Major bleed more with aspirin than placebo. So, and this is where the data came in. You don't have to give triple therapy. Basically, you can send those patients home. I mean, you can start aspirin, clopidogrel, and abciximab in the hospital. When the patient gets discharged, they discharge on clopidogrel and abciximab. No difference in death between aspirin and placebo. Ischemic events, there was no difference. Only thing was the major bleeding in these patients, and actually the number to treat is 13 to prevent one major bleed, which is a big difference in this case.
مصطفى في صدى للصوت اذا تقدر ما بعرف شنو من عندك او
I don't think I do. I have nobody around me.
Get closer to the microphone. شوف الصوت عندهم مش واضح.
Okay, how about now? Better?
أحسن أيوه.
Okay, great. So the safety and efficacy of antithrombotic strategies in patients with AFib undergoing PCI. This is like a data which gets loaded and can be checked by anyone online. So you get updated about it, but it support the use of dual therapy, avoiding aspirin, the DUAX, the preferred anticoagulant, more than the warfarin, vitamin K inhibitors and DAP should be avoided at this point. But it doesn't mean that you limit your patients if they cannot afford it, because that will drain their budget. So the tips or the for any exam you guys gonna go through antiplatelet agents. We have to be aware that prasugrel black box warning. Don't use it with patients who have TIA or stroke, patients who have a low weight. Got to decrease the patients who are older 75. Avoid it. If the only option, use a lower dose. Optimal timing for P2Y12 inhibitors is unresolved. Nowadays with ACS is basically 12 months. You don't want to use it more than that, except in very selected patients. If it's elective, you can use for 6 months. Nowadays, people, they talk up to 3 months. If there's an urgent surgery, it needs to be done, but the guidelines supporting it's still 12 months in these patients. Minimize the use of 2B3A inhibitors because of high risk of bleeding. Don't use it as an upstream from the emergency room. Use it only, use your judgment in the cath lab, especially if the patient was not loaded with the P2Y2 inhibitors. Clopidogrel for pharmacoinvasive strategy. If on OWAX, we use, as we said, we don't triple therapy. We use only double therapy. We use the dose reduction in older patients with advanced chronic kidney disease. Normally, the preferred OWAX in these patients is apixaban. Anticoagulation, keep it simple. We use unfractionated heparin. We don't, or low molecular weight heparin. We don't use fendovernax, of course, and we don't use bavloridine nowadays. So that for 12 months, even if not PCI and less high bleeding risk. Secondary prevention measures, there's no tricks here. You can use basically use statins, simple antiplatelet agent, if needs OWAX, be early, be brave, review recent OWAX trial. As we said, all this data get loaded, and then you can always review with the way you treat your patients. Now we go to the first case. I'm open for discussion here if anybody wants to ask any question, but I'm going to mention. So 63 years old, a female, came to the ED, 5 days history of chest pain, stable angina, history of hypertension, has TIA 2 years ago, has severe COPD on intermittent oxygen. Her pulse rate is regular. Her EKG shows ST changes. She was rolled in as non-STEMI, started an IV heparin nitro, discomfort resolved, EKG normalized, plan to cath next day. So what do you give her? You give 5 milligram intravenous metoprolol. As we said, intravenous metoprolol, we don't use it anymore. There's a high risk of shock and hypotension. We used to use it for arrhythmias, but nowadays we don't. So do you upload this patient with 300 milligram of clopidogrel? Yes, and that's the right answer just for the sake of time. You can load with 300 or 600. Normally, if the day before you can load with 300, next day you start 75. The difference between 300 and 600, basically it acts, it's the start to work faster. If you give 300, maybe start work in the 6 hours time. If you give 600, it'll take at least 3 hours to start to kick in. Or you give 60 milligram prasugrel, we said we don't in these patients, but also it's contraindicated in the patient we have because of the history of TIA. Now, we don't use aptiphetide, which is a 2B3 inhibitors, or use or intravenous cangrelor for the same discussion we did. Now, patient, they will tell you, why don't just don't use anything. This patient she's an IV heparin, she's a nitro, she has no more chest pain. Why don't maybe she has 3 vessel disease? Why use Plavix? Then the patient will stuck for at least a week in the hospital waiting for open heart surgery. Now, as we discussed, most of these patients we can treat in the cath lab, even if they have left main or 3 vessel disease nowadays. But notice this patient also has COPD. She's on oxygen therapy. So we think even if she needs open heart surgery and you get a surgeon, depends on how aggressive is your partner surgeon, whether they're going to operate in patients who have severe COPD and using oxygen therapy. So these are the points. Just pay attention in this question. The next question is 75 years old, has anterior STEMI, successful PCI to occluded LAD. Course was uncomplicated, EF of 38% with anterolateral hypokinesis, started NDAPT, aspirin, ticagrelor, metoprolol, spironolactone. Based on the results of COLCAT trial, we also consider adding colchicine, which is, as we discussed, as an anti-inflammatory agent. It's basically it's an anti-gout medication. We use it a lot in patients with pericarditis. It's a marvelous drug in that avenue. Now, the benefit based on the COLCAT trial, significant decrease in mortality, we know it doesn't. A significant decreased risk of stent thrombosis, we know it doesn't make a difference. Significant decreased risk of recurrent MI, we know it doesn't. So there's a 10% chance of diarrhea, yes. All the above, of course, is no. So basically, nowadays the standard, if you dissect the COLCAT trial carefully, you will not use colchicine. There's some people still use it as an anti-inflammatory agent because there are some difficult patients actually whom really have, they keep coming back with recurrent, events, and we have really no options. We end up adding colchicines in those patients, individual basis based on your experience and your area you manage patients. Last case, 70 years old gentleman with history of non-STEMI, has AFib. This is just to examine the use of triple therapy in these patients, hypertension, diabetes, and he's on ACE, aspirin. EKG showed AFib with the heart rate of 80, controlled. Coronary angiogram shows critical stenosis, mid-LAD. PCI was done. We use mostly drug-eluting stents in the United States. There is no more place for bare metal stents. There's no benefit, especially with the second generation drug-eluting stents nowadays. Even the use of, they say if you use bare metal stent, the classic teaching, they said, oh, you can use only Plavix for a month and then stop it. Actually, this is based on, there's no comparison head-to-head between drug-eluting stents, and it's based on old trials. Basically, nowadays, bare metal stents, they have no place. Now, and then because of the patient has AFib, you need to make a decision whether do you send these patients on DAPT and OAX or DAPT and warfarin, and then for how long do you use it? As we discussed in the previous trials, especially the Twilight trial, basically use apixaban, DAPT, and discontinue aspirin after 1 week. Normally, we do triple therapy during hospitalization. and then we discharge patients on basically on clopidogrel and apixaban. We prefer not to use warfarin. There's a higher risk of bleeding, but as I said, it doesn't mean sometimes we don't use it. And then actually the rivaroxaban was not studied in this case, so we use apixaban at this point. It doesn't mean that you cannot use it. And then that's it. If anybody has any questions, please let me know. And thank you all.
Doug, just going back for a second with the aspirin, when we were just reviewing the studies, it was just saying, I was thinking C. I mean, do they need to discontinue between A and C? Does that discharge after the hospital, we can discontinue immediately with the aspirin?
Yes. So basically, the patient come in, you put stents in them, right?
Right.
And let's stay with you for 2 or 3 days, right?
Mm-hmm. Right.
Now, so I would send the patient home an apixaban and just clopidogrel, no aspirin.
Right.
There's a higher risk if you continue aspirin. Now, if you look at the practice, I would say 3 years ago, we used to say do triple therapy for a month, right?
Mm-hmm.
And then you can stop the aspirin after that. Now we stopped doing that. We send patients only on apixaban and clopidogrel, no aspirin. Now I get burned with one of my patients. Actually, she went home and then she has bleeding. She had intracranial bleed, so I stopped doing that. So in general, that's what we do.
In this case, for the sake of the question here, was that just that after 1 week, that between the A and C, was that just, you know?
Okay. Discontinue aspirin after 1 week.
Yeah.
No. So, but that's apixaban and that for 12 months, right?
Right.
So we're going to use A.
Okay.
What about warfarin? Why it is wrong in this? Why D is wrong?
It is wrong because based on the trial, remember we said there's a higher risk of bleeding with warfarin.
Yeah.
Right. Now, mostly, I mean, even if you look at the normal studies comparing the AWACS and warfarin, even for without MI for AFib or for DVTs, all the studies showed the AWACS are much safer, mostly because warfarin you cannot control. There's a higher risk of intracranial bleed with warfarin because it's unpredictable in these patients. So normally, actually, we run away from warfarin. We have only very small number in our practice patients on warfarin. Those patients who cannot afford it, or those patients has been very stable on it, no change in the dose and all this. But how many of those patients do you get, to be honest with you? So it makes sense that warfarin will increase high risk of bleeding. Now, remember, you're dealing with a whole population. Now, in individuals, you can individualize this care based on from individual to individual. But nowadays, because it's unpredictable, that's why we don't use warfarin in this case.
So practically, let's say in a low socioeconomic status, with we know apixaban is a little bit more expensive than warfarin. If the person cannot use apixaban and they've been on warfarin for AFib for a long time and they've been stabilized.
Yes, for sure. You just give them clopidogrel and continue warfarin.
And warfarin, okay. So you okay.
Yeah.
All right, we have 3 questions. The first, you may have answered some questions, but probably reiteration will be good for the listeners. The first question is, after BCI, which better to use, prasugrel or ticagrelor? And how long can patients stay on prasugrel?
Right. Now, the prasugrel, now it's really, I mean, you could use prasugrel. Hello?
Yeah.
Yes. So now, based on the ISAR trial, which was in New England Journal in 2019, there is no difference between prasugrel and ticagrelor in terms of bleeding risk or MI or so on. Now, the prasugrel has a black box in patients who have history of TIA or stroke, and also patients who have a low weight, less than 60 kilograms. So those patients are much higher risk of intracranial bleed and prasugrel. So we don't use it, right? So now if you have older people and you have only option is prasugrel, then you gotta use 5 milligrams. In terms of the duration, you just follow up the regular guidelines. If you have patients with acute coronary syndrome, basically unstable angina, non-STEMI or STEMI, you use dual antiplatelet for 12 months. Now, either you combine prasugrel or ticagrelor with aspirin, or you combine it with clopidogrel. Now, of course, if it's elective intervention, you can use these drugs only for 6 months and just continue aspirin after. Hopefully that's clear.
Yeah. So the second question is if LV systolic function is between 40 to 50, can we use aldosterone antagonist?
Now, of course you can, but the benefit is withdrawn from if your EF is less than 40%. Now, we know there is a mortality benefit mostly if EF is less than 35%, but the guidelines, the consensus, and the people who are sitting on the board, they say 40%. Now, can you use it? Yes, of course you can. Do I use it myself personally? I do in patients who have like a large MIs. I use it out of the bed and maybe I continue for a month. But the benefit you draw from the aldosterone if your EF is less than 40%, like similar to ACE inhibitors.
Okay. Okay. This question you may have already answered it, but let's reiterate that. Can we use DUAC, dual direct oral anticoagulant such as apixaban routinely after BCI, or only if associated with AFib?
Only if associated with AFib. There's no rule of DUAC in patients who have no AFib or no other thrombotic events.
Okay.
Because remember, this is a platelet aggregation. It is not really anticoagulants. But I mean, of course, as you see that there's the Atlas trial, which has 15,000 patients in it. And those guys, they're trying to push us to use rivaroxaban in these patients, but there's a high risk of intracranial bleed in those patients. So really, we're shying away from using it. Now, definitely, if there's only, to answer the question, only if there's AFib or PE or DVT on those patients, you use apixaban and other B2Y2 inhibitors in those cohorts.
Okay, good. Last question is, if you ended up using colchicine in patient with MI, I know there is controversy about the benefit, but for patient that you use it, how long you recommend it? How long you recommend patients stay on it if they use it?
Now, I think the study, when they did it for a year, but there's a lot of dropout in those cases. Most of them, they drop out because of the GI effects, right? Personally, I use it for 3 months time. And that's just my own personal preference, because I feel like, you give them enough time to use their statins, make sure they're established in aspirin, change their diet, go to cardiac rehab. So all those things will suppress the inflammations. But if I do use it, I use it for this reason. Now, I don't use it routinely myself in patients with acute coronary syndrome, but I use it mostly for patients who have recurrent in-stent restenosis. I use it. I do a lot of my practice. I do a lot of PAD cases, PAD patients as an outpatient. I use it for patients who have recurrent in-stent restenosis for PAD cases, but I don't use it routinely based on the CORCAT trial in patients with ACS.
Good. But I think that is all the question. I have one question is, I'm a hematologist, and it caught my eye that you don't use that much of fundibrenux as an anticoagulation in the peri BCI or on the ACS in general, and I was just wondering, why is there any data to suggest that increased risk?
Yeah, it is. It's difficult to monitor, right?
Mm-hmm.
And then we as cardiologists, we like control. That's the bottom line.
So is it the same for all of the low molecular weight heparin, like enoxaparin, Lovenox, or just it's particularly for Fundabranax?
Only Fundabranax is a long-acting. It's we know it's a safe drug, but we there's some studies people they use Lovenox in cases, but again it makes it very difficult for us because I don't know how to test it in the cath lab. I mean, I cannot just say, check an ACT for me, so I will know whether I give my patients extra heparin or not. So definitely it comes to, at the end of the day, it comes to control. We like control.
Good.
Dr. Hashem, I have one simple question. Actually, I faced this here. Is there a clue in the AKG that would tell you the patient may need a bypass? Like I had a patient with right bundle block, and essentially the hospital decided not to load him with the like Plavix, for example, and he actually ended up we cath him and we found out he has a triple vessel disease. What do you think of that?
No, it's difficult, but let's say you get somebody with mostly patients with non-STEMI, right? You really don't know what they have, right? We don't know what they have. I would say the non-STEMI patients will have more three-vessel disease than STEMI patients. Now, I would shy from loading any patients with the STEMI with the P2Y2 inhibitors, because at the end of the day, you have to fix the culprit vessel anyway, right? So you fix the culprit vessel, and then they can go for a bypass surgery afterward. Now, as we discussed, we send, I mean, in my own practice, but maybe I'm aggressive interventional cardiologist, I send only maybe 2 or 3 patients of my patients for bypass surgery. Now, if you look at the general public throughout the United States, maybe only 10% of the patients that will need to go to open heart surgery. Now, if you have 80%, I mean 90% of the patients, they don't need to go to open heart surgery, right? So do you plan your care for the 10% or for the 90%? Knowing the benefit you would draw from early antiplatelet therapy in these patients and reducing MI size, preserving LV dysfunction, and so on. So you got to factor that into the equation, right? Now, to answer your question from the EKG, I mean, let's say you have somebody who have, ST elevation inferior, you'd think it's an RCA, but if let's say it's inferiolateral, you'll say, oh, is this a large RCA or he has an RCA and then circumflex? It really will be very difficult from the EKG to say this patient will have three-vessel disease. Now, there is patients who have ST elevation and AVR, right? And ST depression and other vessels, right? Those patients, and that's ST elevation now. Now, when you have ST elevation and AVR, and you have ST depression and other vessels, that is not an ST elevation, that's an ischemia. And that ischemia, it could be because of three-vessel disease, either a left main or three-vessel disease. For those patients, you should expect three-vessel disease in them. Hopefully, I did some.
Thank you. Very clear.
You're welcome, no problem.
All right. Thank you, Dr. Mustafa. Very nice, organized, and clear presentation. We appreciate your effort. Inshallah, we will have 2 more lectures of ACS. Is that right, Dr. Mustafa?
Inshallah.
Inshallah. So we'll announce about time of that through the WhatsApp group, and also we'll share it to the people that we know, inshallah. If anybody has any other questions, please feel free to raise your hands or say it, or you can put it in the chat. Otherwise, we will conclude and see you next time, inshallah.